So we're going to talk here about renal disorders in the newborn. And I wanted to talk about some renal disorders that are more specific to the newborn. Obviously, the one that isn't really specific to the newborn here is Hemolytic-Uremic Syndrome, but I wanted to put that in here because you really can't talk about that one enough. It comes up in the test all the time, and it's a relatively poorly understood topic by a lot of residents and students. But really, these other four, are things that you tend to encounter in the newborn more than in children. Renal agenesis, multicystic dysplastic kidney, renal vein thrombosis, and posterior urethral valves. These are some things that you can encounter in newborns. Now, there are a lot of other renal disorders that you can encounter in newborns. So I don't want you to come off thinking that these are the only ones that happen in newborns or the most common ones necessarily. These are just more specific to the newborn. So if you have a baby that has renal failure, and babies who have these conditions may or may not have renal failure, there are some things that you're going to want to have. So typically you diagnose renal failure based off of a deranged metabolic profile, but you're going to want to, of course, have that metabolic profile, and you also want to have some levels of some other electrolytes, and that's going to include phosphorus, magnesium, and calcium, because these can often be deranged in renal failure. You also want to have a CBC. A lot of times sepsis is a cause of renal failure, and so you want to see if there's any abnormalities there. Your urinalysis is important. If you have any casts or sediment, that can give you hints towards usually an intrinsic cause. And then electrolyte levels in your urine will also be important. And then renal sonography and Doppler, looking to see if there's any enlargement of the kidneys, if there's any thrombosis. And then also you can get some ideas of the vascularization, as well as the tissue itself, if the tissue is diseased. So this is really just the basic workup for renal failure in the newborn. There are other tests that you may want to get, but this is just the bare minimum. All right, so renal agenesis is absent renal development. It can be unilateral or bilateral. So typically, if a baby is born alive, it's usually unilateral. But you can have bilateral renal agenesis, and we're going to see that's related to something that's called Potter syndrome, where the kidneys don't develop, and therefore the lungs don't develop, and almost always that's incompatible with life. But if it is unilateral, the baby will typically have a normal renal function in the other kidney, and that's enough to keep the baby alive, and generally that's typically fine. So if a baby does have one kidney that hasn't developed properly or isn't developed, then it should prompt an investigation for other congenital anomalies. Particularly here, we're thinking of the Bacterial sequence. So vertebral anomalies, imperforate anus, cardiac anomalies, tracheoesophageal fistula, and then limb anomalies. When you have unilateral agenesis, if you look at the other kidney, the normal or the functioning kidney through the ultrasound, it's typically hyperplastic, and there'll usually be some hydronephrosis. There also, in a minority of cases, be some level of vesicular-uteral reflux, and that can predispose the child to pyelonephritis, and so that you'll want to watch that. In females, there is often a coexisting Müllerian agenesis, and you might know this better by the eponymous name. Let's see if I can say it. Meyer-Rokitansky-Kuster-Hauser syndrome. That is a mouthful. So Müllerian agenesis is easier. And all that is in the kidney that didn't develop on that side, there is often on that side, the Müllerian structures didn't develop, and so there won't be half of the uterus might not be developed, and the fallopian tube on that side might not be developed, or you may just have total Müllerian agenesis, and the vagina won't be, it'll be an impatent vagina, there won't be a uterus, there won't be fallopian tubes. But there will be ovaries, because that's not part of the Müllerian system. So in females, you should check the patency of the vagina. You should look with ultrasonography for the Mullerian structures, including the uterus and the fallopian tubes. Now, when you have bilateral agenesis, this is incompatible with life. And it's not incompatible with life because the baby doesn't have any kidneys. Lots of people don't have functioning kidneys and they live perfectly fine. Well, not perfectly fine, but they live on dialysis. But if a baby doesn't have kidneys and didn't have kidneys during fetal development, what likely happened was they weren't producing enough amniotic fluid. They weren't producing enough urine in that to create enough amniotic fluid, and that amniotic fluid is breathed in, and that fluid then helps the lungs develop. If that process doesn't happen, where amniotic fluid is not helping the lungs develop, there's not enough amniotic fluid, which is usually because there's two kidneys that aren't working or there's an obstruction, then the baby will typically be born either stillbirth or have severe respiratory distress and die shortly after birth because the lungs aren't functioning. Now, often this is diagnosed prenatally. The mothers will usually have severe oligohydramnios. They're just not getting to the size they should be for their level of pregnancy because there's not that amount of amniotic fluid. When you think about a woman who's pregnant, you look at her belly, that's not all baby in there. That's a lot of fluid. And any woman who's been pregnant knows this because when she goes into labor, it's that big gush of fluid, and that's what is nourishing the baby's lungs. So usually the mothers who give birth to these babies will have oligohydramnios during their pregnancy. And then this is associated with Potter's syndrome. And really, it is Potter's syndrome. When there's not enough amniotic fluid, the kidneys aren't working, or there's an obstruction and you're not getting the urine into the amniotic fluid, and therefore you have respiratory problems. That's what Potter's syndrome is. So Potter's syndrome is also associated with these dysmorphic features that are seen, and that's due to the compression because there's not enough amniotic fluid. You can think of the amniotic fluid as sort of a cushion for the baby, and so if there's not enough amniotic fluid, the baby's face and limbs will be compressed. And that's typically secondary to bilateral renal agenesis, but it really can be due to anything that sufficiently obstructs urinary outflow. So if there's urethral atresia on both sides, if there's obstruction on both sides, if there's enough obstruction in the urethra, and when we talk about posterior urethral valves, those can be severe enough to cause Potter's syndrome. Or if there's bilateral multicystic kidney disease that affects the function enough, those can all lead to Potter's syndrome. So the features you see in Potter's syndrome are the eponymous Potter's facies, and these are widely separated eyes with an epicanthal fold, these really characteristic folds beneath the eyes. I'll show you some pictures and you'll see what those are. They have a broad and compressed nose, and that just has to do with the compression because of the oligohydramnios, and a very, very small receded chin. That chin's kind of almost pointed backwards. They'll also have limb anomalies, and the really characteristic one here is Sirenomelia, and that is almost always, any case of Sirenomelia is pretty much going to be in association with Potter's syndrome. Not all babies with Potter's syndrome will have Sirenomelia, but almost all the babies with Sirenomelia got it from Potter's syndrome. And then also clubbed feet, so those are the limb anomalies that you see. And until very recently, there were no survivors. This very, very recently. So I'm going to show you the latest on that. So this is a baby that was born with Potter's syndrome, and these are those very wide folds. You see the broadened nose and really a almost backwards facing chin. Very small chin, but backwards facing. You'd have to see the side in order to appreciate it. But note these big folds. That's going to give you that's going to be your key to noting Potter's syndrome. So here again, you see those very prominent folds, very broad nose again here, and again you see this sort of almost retroverted chin, very small chin. This is Sirenomelia, so some people call this mermaid syndrome because the baby has fused lower limbs. Also, another thing, we didn't see this, I don't think, in these other ones. You'll have very low ears in Potter syndrome. These ears are very low. So that's something you'll want to remember too. So again, here you can see the low ears, you can see those folds, you can see obvious limb anomalies here, and kind of see this baby's chin is relatively normal. It's going to vary from baby to baby, but you see this constellation. Also, you can see the very flattened nose here. Okay, so remember I was saying that until very recently, there were no survivors. So this is a congresswoman from Washington. Her name's Jamie Herrera Butler, and she became pregnant about 2.5 years ago, and was told that her baby would not survive because she had Potter syndrome and she didn't have any kidneys. She actually underwent a prenatal amniotransfusion. It's a experimental treatment for Potter syndrome. And basically, I mean, you think of the physiology behind Potter syndrome, they're putting in saline into the uterus to make more amniotic fluid, just synthetic amniotic fluid. And so the baby's lungs would develop. And because that's really where the problem is in Potter syndrome, is that the lungs don't develop. And indeed, the lungs did develop, and this baby is now 1.5 years old, and she doesn't have kidneys. She will need to be on dialysis, but she can get a transplant or be on dialysis. But the important thing is she was born alive and she's healthy. So that's pretty miraculous. All right, moving on to something else, multicystic dysplastic kidney. This is the #1 cause of a palpable abdominal mass in the neonate, and it's characterized by multiple cystic malformations on a single kidney. And it can affect both kidneys, but that's going to cause Potter syndrome. Now, if you see cysts on both kidneys, that's going to be probably autosomal recessive polycystic kidney disorder. In multicystic dysplastic kidney, you have cysts on one kidney, and that kidney also doesn't function. Whereas with the polycystic kidney disorders, the kidney usually functions to a certain extent. Typically, this is not associated with renal failure because the other kidney is going to compensate. Typically, with multicystic kidney, you've got one kidney that is working and the other kidney is affected. So this is typically diagnosed prenatally, and then the contralateral kidney will usually have a degree of hydronephrosis, about 5 to 10%, and that should prompt avoiding cystourethrogram because there can be a possible ureterocele in these cases. There is an increased risk of Wilms tumor in multicystic dysplastic kidney, and there's also an increased risk of hypertension. The treatment is just going to be to follow these children up with sonography, looking for a Wilms tumor, and blood pressure measurements to make sure that they're not going into hypertension. If there is an enlargement of the dysplastic kidney or if hypertension develops, then you can go ahead and do nephrectomy. Some surgeons would recommend doing a nephrectomy prophylactically without doing all the follow-up, just do the nephrectomy, but you can go either route. So here's a multicystic dysplastic kidney. You can see the very large cysts here. Hemolytic-Uremic Syndrome is an acute condition that is characterized by 3 things. You have a microangiopathic hemolytic anemia, a renal insult, which will be reflected in a certain degree of renal failure, and then you'll also have thrombocytopenia. And that's a very, very important feature in this syndrome. If the symptoms came on and within the last week and the child does not have thrombocytopenia, you really should be thinking of something else. So let's take a better look at this. So the microangiopathic hemolytic anemia you're going to have a decrease in hemoglobin and hematocrit. And the reason that you have this hemolytic anemia is because the red blood cells are suffering trauma from hitting the clots that are in the microvasculature. So these red blood cells are going to be destroyed, and that's going to decrease the hemoglobin and hematocrits. You can also see these damaged red blood cells on the smear, and the schistocytes, Burr cells, and helmet cells. And then you can also, of course, get an increased indirect bilirubin, and that's due to the hemolysis. The renal insult will be reflected in the elevated creatinine. You can also have hematuria and proteinuria. The severity of that, though, is going to vary. And then finally, thrombocytopenia. It's invariably less than 150,000 in the first week. Usually it gets even lower than that, as low as 20,000 or lower. Typically, hemolytic-uremic syndrome will follow a diarrhea illness, and classically it's E. coli 0157H7 strand. But it can be associated with other pathogens as well. Particularly, strep pneumococcus can produce a neuraminidase that can lead to HUS. So there are really a lot of infections that can lead to HUS, but the classic one is the diarrheal illness, and that's going to be the one you'll see most often. It can be difficult to differentiate from TTP. But the major clue is going to be that hemolytic-uremic syndrome is usually follows some kind of a recent illness, either upper respiratory infection or more commonly a diarrheal infection. And also remember that E. coli 0157H7 causes a bloody diarrhea, so that'll be a good hint for you. So TTP, in case you didn't remember, that's thrombotic thrombocytopenic purpura. And that tends to also run in families. Okay, so this is just your process that goes on in hemolytic-uremic syndrome. So you have that usually diarrheal process. About a week later, you get HUS, and then that's going to cause these three cardinal manifestations: microangiopathic, hemolytic anemia, thrombocytopenic state, and then acute kidney injury. And about 50%, I'm not exactly sure what RRT means. I think that means that they'll go on to need some kind of transfusion. Renal replacement therapy, that's what it means. Okay, so that means they're going to need dialysis. And then 5 to 10% will have renal sequelae later. 5 to 7% mortality. So this is not something you want to play around with. If a child is diagnosed with hemolytic-uremic syndrome, they are always going to be admitted. And 70% of HUS comes from entropathic hemolytic E. coli. I believe that's what that stands for, EHEC, entropathic hemolytic E. coli. I'll look that up. I'll give you a little caption underneath if I'm wrong. Okay, so here's, you may be given this on the test because this is really basic knowledge. So these are schistocytes, and these are just red blood cells that have been damaged through MAHA. These are helmet cells, and it's pretty much the same thing. They're damaged from the microvascular disease. And then these are Burr cells here. Okay, so the management for hemolytic-uremic syndrome is primarily supportive. You're going to be giving fluid resuscitation, since most of these children are going to be dehydrated from the diarrhea, and then maintenance to balance their urinary output. And for that, you're going to want them on strict INOs because they are at risk for becoming fluid overloaded. Of course, these are going to be admits either to the general floor or probably even more commonly to the pediatric intensive care unit. You want to consult pediatric nephrology because of the risk of renal sequelae from this. You want to have frequent monitoring of electrolytes because these children are usually in some level of acute renal failure. Want to make sure that you're keeping an eye on the potassium. And then if the children become symptomatic, if their anemia becomes symptomatic, you can give them packed red blood cells. Usually the cutoff level is going to be 7 grams per deciliter. If they go below that, we can give them packed red blood cells. But anything above that, we try to avoid it if possible. Also, we try to avoid platelet administration. The cutoff is usually 20,000. I would say if you're tacking a USMLE question, don't do platelet administration. And then dialyze if necessary. Renal vein thrombosis is a thrombosis of the renal vein, that would make sense, which in newborns is typically associated with hypoxia. It's also seen a lot in newborns that are born to diabetic mothers. It can also be due or aggravated by dehydration, shock, sepsis, hypercoagulable states. Also, and I believe this is because the same reason for infants of diabetic mothers, but babies who have very viscous blood, who are have a high hemoglobin count, so polycythemia. The manifestations of renal vein thrombosis are going to be typically a flank mass, and that's just because of the increased back pressure from the kidney. Hematuria is usually going to be present. If there's bilateral renal vein thromboses, there'll be acute renal failure. However, if it's just unilateral, then the renal function should be fine. In unilateral renal vein thrombosis, there usually will become from that a hypertension, and that's due to activation of the renin-angiotensin-aldosterone system. So think about it. You're not getting appropriate blood flow to the kidneys. Things are backed up. The kidneys are going to sense that as deprivation, as dehydration, and what are they going to do? They're going to secrete renin to try to pull in water. Your kidneys don't know anything else than the amount of blood it's getting. And when there's a backup, it's going to restrict the blood flow. It's going to result in resistance. So that's going to result in decreased blood flow to that kidney. And your kidney doesn't know the difference between it's not getting blood or you're dehydrated, and so it's going to think you're dehydrated, and what's going to result from that is it's going to secrete renin, and that's going to set off the cascade where you'll get aldosterone and reabsorb sodium, and that's going to result in hypertension. For diagnosis here, I've heard some people say that that it can be diagnosed on clinical grounds. I'm skeptical of that. I think sonography is very cheap and it's very easy, and particularly Doppler sonography is really good at diagnosing thrombi. So I would say that would be the best initial test for diagnosing renal vein thrombosis. Also because a flank mass in a baby can be so many different things. This should also include assessment of the main renal vein and also the inferior vena cava, because that thrombus can spread. And so you want to know how much of the vasculature that thrombus is including. So the management here is going to be supportive care for any acute renal failure. Like I said, typically you're not going to see that because it's usually unilateral. But if it is bilateral, you can have renal failure. You're going to want to have consultations to peds nephrology and vascular surgery. The hypertension can usually be managed medically. Usually calcium channel blockers are given to very, very little babies. But in older babies and toddlers, you can give them ACE inhibitors. Nephrectomy can be considered if the hypertension does not respond to medical treatment, but we would like to try to avoid that because of surgery. And then this is important here. So you want to work them up for hypercoagulation, because hypercoagulation is a big risk factor for renal vein thrombosis, and renal vein thrombosis can be a manifestation of hypercoagulation. So you want to look at all these different things that can cause hypercoagulation. Now, I included a lot. The big ones that you should be aware of are protein C and S deficiency, factor V Leiden, and when you're talking about an infant, the MTHFR mutation. So this is an enzyme, I think it's methionine tetrahydrofolate reductase, don't quote me, but this is responsible for catabolizing homocysteine. And this is the mutation that is present in children with homocystinuria. And homocystinuria is a risk factor for thrombi, puts you in a hypercoagulable state. All right, so finally we'll talk about posterior urethral valves. This is the most common cause of obstructive uropathy in pediatrics, and it affects 1 in 8,000 boys, and typically the boys are affected in this disease, but girls can be affected as well. The valves will extend from the external urinary sphincter to the prostatic urethra. That's considered the posterior urethra. And that obstructs urinary outflow. And the severity really just depends on how many valves there are and how much give they have, I suppose you could say. And so the severity really goes from just a mild hydronephrosis and post-renal failure to just flat-out oligohydramnios and Potter's syndrome. So really, it can span it can span the whole range of fetal renal failure. The symptoms are typically going to be a palpable pelvic mass, as well as oliguria or anuria. So the oliguria and anuria is because there's valves and the baby can't get the urine out, and so because of that, there'll be bladder hypertrophy and filling. So that's going to be your palpable mass. And so you'll be able to suspect this based on your clinical findings and then also sonography, and you get a very, 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 very characteristic sign on sonography that's going to make you pretty much assume this, but you cannot diagnose this for certainty until you do a voiding cysturethogram. That's the most accurate test, and that's what the urologist is going to want to have before they do the actual surgery to treat this. So on sonography, so this is a prenatal sonogram, so you can actually see it here. You can see that the bladder is distended, and the bladder is distended because there's too much urine in the bladder, and there's also a distension here. And that is what you would see in the baby after they're born, and that is called the keyhole sign. So this is the keyhole sign, and you have here this distended bladder. And that's what it looks like. So this is characteristic of posterior urethral valves. And you see it again. So there's a keyhole. And then when you do the voiding cysturethogram, you'll be able to notice the valves. That'll be a filling defect. And then you should also have a dilated prostatic urethra. That's right here. That's the little part of the keyhole. So, see, here. And then you can see there's valves here. I think I've got one more. Yeah. Okay, so here you can see another valve there. This is the voiding cysturethogram, and then the treatment is going to be a consultation, obviously, to pediatric urology. They're really going to be doing the VCUG, and they'll be doing the treatment. What you can do is carefully pass a 5 French catheter up the urethra, not a Foley catheter. Foley catheter has a balloon on it, and that can make things worse, so you're using a 5 French catheter. Usually that's what you use for feeding tubes, and this can also be part of your diagnostic workup, and what you can do then is drain the bladder, but what you'll typically notice, and this is characteristic of posterior urethral valves, is this resistance, and that's the valves. When creatinine levels have normalized, because most of these babies are in post-renal failure, and the patient is stable, and they've had a voiding cysturethogram to diagnose them with posterior urethral valves, then the urologist, at their discretion, can do a transurethral ablation of the valve leaflets, and that's curative. These babies, though, are going to need to be on antibiotic prophylaxis for some time because they're going to have an increased UTI risk. They're also going to need follow-ups with a pediatric nephrologist or just a general pediatrician because they have increased risk for UTI, and they also are probably going to have bladder continence issues when they reach toilet training age. And that is all I got.